All right, we have Dr. Beninati here. So excited to have you, and I would love to have you just give a little introduction, give a little bit about your background before we get into talking about hormone replacement.
Well, my backgrounds, after delivering about around 4,300 to 4,500 kids in Chester County, 30 some years, I decided to do something differently and involved mostly into clinical nutrition. At that time, that was the father of the functional medicine, and which in functional medicine now is we do the same thing then in clinical nutrition, and that opened as I say, I jumped the fence and went to the other side of the complementary and alternative medicine, which was amazed.
Mm-hmm.
All data is based on scientific data, not anecdotal anymore. It's not that the story because the Chinese used it before. No, no, no. Studies have shown this is proven to be of benefit. That's the type of medicine I do.
And
Uh,
what made you kind of make that shift, just even in your mind, of conventional medicine to more of functional medicine?
I was always interested in the importance of nutrition, of course. And then, as we know that as a nutrition, that, you are what you eat. The
Mhm.
Italians say that all the time, you know what I mean? So then I did also loved fascination about women's physiology. That's why I became in gynecology, because the all the endocrine system of the woman reproduction, and it's fascinating always me. So I always liked that idea. So and then I incorporated hormone replacement, and the first time we did the wrong hormone replacement that was dictated by our college OBGYN, which was the synthetics, and then we saw the bad results on that one. Okay, yeah, so that make the switch to know more about bioidenticals. That's why I took the course in bioidentical, and that's what's from then on I incorporated into my practice.
Awesome. And what were some of the things that you found then as it relates to synthetic hormones? What were some of the negative things that you were seeing in your practice?
Well, the what we see right now is uh, that the bioidentical replacement of the hormones are exactly what the body needs. The body doesn't need a pharmaceutical like has estrogenic effect or pharmaceutical that like some progesterone effect. You need the real progesterone, you need a near estradiol, you need a near testosterone, you need a near DHEA, you need the real thyroid.
Mhm.
So, so I don't know if I answered the question correctly, but
That's okay. Just kind of, what were some of the negative things
no,
that
the
you
idea also there are some pharmaceuticals that are doing into right now. They're going into onto the bioidenticals.
Mhm.
So they're doing some. Okay. Now
Yeah.
the thing this is threat because the FDA has they're trying to eliminate it because it's a make competition for the pharmaceuticals. And not
Mhm.
only that, people that are doing bioidentical hormone replacement in general, there are people that are much healthier because they eat healthier, they're more conscientious about the nutrition, they
Mhm.
have more energy to exercise, which is essential. It's not exercising is not negotiable. And like I said to the patient, and not cooking is not negotiable. You have to cook, unfortunately. Look, sooner or later, you have to cook. And
Right.
exercise.
And that's kind of, I'm sure that you see this in your practice, but of course I do it in our setting, which is, a lot of people have poor sleep habits, poor eating habits. They're not exercising. They have high stress levels. So of course that's going to throw their hormonal and their hormones out of balance. So do you believe that it's always really important before someone even gets to the hormone replacement stage to try to really address those lifestyle factors?
Definitely, but it depends. It depends
Okay.
on the age of the person. If the person's already perimenopausal, they have some symptoms or
Mhm.
problems related to their hormones. Okay, obviously, you have to get a comprehensive and integrated approach. You have to put the nutrition, uh, the exercise, the stress management, and so on. But sometimes they need a booster. They need
Yep.
something to feel better. And so sometimes we start with the hormones, but any patient that comes to my office, uh, even men with testosterone, low testosterone, whatever it is, I told them right now, if you don't exercise, if you don't eat properly, you don't manage your stress, and you don't sleep, the results of any hormone replacement is going to be mediocre. It's not going to be the wow,
Right.
one, I feel great. It's not going to happen. So,
Mm-hmm.
and they make a sign of consent. And I give we talk about nutrition, even little things that we should be eating. This is a booklet, but some supplements you have to be taking. That's what you do for stress. So we do, and we need to refer to somebody do it. But in general, there's a big decrease or increase in demand for hormones because the lifestyle is not conducive to good hormones either. So it's a vicious circle.
Mm-hmm.
And another thing we see right now, our toxin environment. We are bombarded with this xenoestrogen or hormone disruptors.
Yes.
Any,
Can you explain that a little bit? All of the toxic exposure and pesticides and.
well, anything that comes from the oil, okay, it is by default, it is hormone disruptors. And women have increased risk of breast cancer, as we know right now. In men, also prostate cancer, but in men also act as an anti-estrogenic, androgenic, blocks the receptor. It's a bigger impact in men than in women, but in women has also suffered infertility issues, irregular cycles, because we are bombarded with this chemicals. There's I don't know, thousands, you know what I mean? It's mostly all derivative, all come in from the plastic. Now, for example, we know at BPA. Now, say BPA free, okay, but they use BPS. It's bad. All the BPAs are bad, and whatever letters they put, P, S, F, you know what I mean, A. So BPA free is relative. Okay, in plastics, you know what I mean? So
I'm sorry.
Yeah,
Go ahead.
we mentioned that. We mentioned when you see that balance of hormones, they do patients are informed about how to avoid the toxin, because certain things you can do. Other things, even though we try the best in nutrition and we try to avoid all doing everything organic, there's so much in the water, in the air.
Yeah.
It's horrendous. You know, and chloride, I'm surprised about right now what's going to happen with chlorine. Chlorine is a hormone disruptor.
Right.
And we're going to see more problem, maybe, because we're using all the disinfectants and chlorine everywhere, you know what I mean? So I'm concerned about that too.
So equally as important as the sleep and nutrition and exercise really is trying to limit toxic exposure.
Right.
Because that, especially as it relates to everything health related, but definitely as it relates to hormones, I think that's a really important thing because we really are surrounded by them. So even if you try to limit your exposure, we still have them all around us. So I think that's a really, really good point. Now, when people come in, Dr. Beninati, with symptoms, what would be some of the things that they might complain of? So anxiety, depression, weight gain, etc.
All of that.
All of that. Anything else that?
All of that, we know as hormones regulates every activity, cells or tissue throughout the body. So optimizing, better term than balancing, and I'll tell you why. Okay, well, let's talk about optimizing. Are essential for good health and feeling of well-being. So all the hormones, estrogen, testosterone, progesterone, thyroid, DHEA, cortisol play a serious role in the life, in the daily life and health. And any imbalance of them creates a big impact dramatically. So, but another hormone we have to not neglect is insulin, which unfortunately, some of the hormone disruptors also interfere with insulin. That's what we see an epidemic of obesity, not only because of terrible eating habits and the lack of exercise, is because of this hormone disruptors, which is just, and this is one hormone that we have to address too. You know what I mean? Is how to decrease. That's where the people come in to me and I say, well, how to decrease your insulin is going, it's inflammatory, your insulin is doing this, you have a gut. So what do you do? And then we talk about intermittent fasting, the importance of limited your carbs or good carbs.
Yep.
They do receive, when I come to the office, they receive a lot of, I'm fanatic about nutrition anyhow, so it's important. They hear awesome. On the importance of that. So as we age, we get more symptoms and signs from hormones balance.
And so,
Plus our lifestyle, as you know right now, under stress. Okay, and the body under stress, the cortisol goes up, adrenaline goes up. The body is trying to defend because being chased by the tiger. So the first thing it shuts off is digestion, as you know right now, and shuts off completely hormones because including the thyroid. In women, ovulatory issues.
So definitely impacts thyroid and then sex hormones.
Testosterone levels, all of them. So stress, is a major issue.
Yeah.
So we do measure cortisol, we do salivary and times, and then I'll explain the patient the importance of that. But sometimes, even though we know that the idea of functional medicine got to the root of the problem, but sometimes you need a booster. So if a gentleman comes here, the woman comes here with their hormones all down, and we know that there's cortisol related, so I want to work with that. But in the meantime, at that moment, to get it out from the hole that they are right in, they need to see, and I see what happened later on. You can say, well, we'll see if corrected. As we get old, that is a different story. We do an anti-aging medicine, which I hate to use anti-aging. You asked me a question about anti-aging before. I'm going to jump onto that. But we are doing in a functional medicine, and is the anti-accelerated aging.
There we go. I like that.
Aging cannot be stopped.
Right. I like that.
I would like to do the idea of healthy aging. I want
to and longevity.
Longevity, a life, active, productive life. Free of the disabilities that impair our life, like severe arthritis, arthrosis, osteoporosis, Alzheimer's. That's going to come up later on. Cardiovascular disease, women specific. What happened to women after menopause? Women after menopause equal the amount of heart attacks men because the testosterone is gone. So
and I think
the estrogen. Sorry, the estrogen is gone.
I think that people
testosterone in women is coming down after 30, 35 down. So and it's more related to lifestyle and the hormone disruptors and in some degree of bad nutrition, because when you have belly fat, the belly fat produce a lot of inflammation and produce a lot of insulin resistance. Then in fact, what the ovary is going to do, the ovary is going to get insulin resistant of the ovary. And PCOS, polycystic ovarian syndrome, which is a very, very common, the most common endocrine disruption we see in women. It's very common. And it doesn't go away, with age. Even though after menopause, you still see that.
Right. And do you think, I'm just reiterating what you're saying, but, everyone deserves to feel good. And I think sometimes people don't necessarily know where to start and recognize that things like bioidenticals, which we'll talk about in just a moment, are an option. And it is something that you could potentially use in your, overall lifestyle to make sure that you are not depressed or anxious or consistently gaining weight or so on. Do you agree with that philosophy?
Definitely, yes.
Yeah. So can you tell me, Dr. Beninati, just a little bit about it, however you want to go about this, but just talking a little bit about what bioidenticals are and kind of like what they're made from, and also maybe the delivery of them?
Yeah, well, the bioidentical is the use of hormones that are identical in the molecular structures to the hormones that are naturally produced by the human body. That's the
definition.
Using natural, no, because they're not natural in a way. The only natural hormones we have is Premarin from the urine of the pregnant mares. But it's natural for the horses, not for a human. But that's natural. And the other is, of course, that we use a lot of desiccated thyroid extract from the pork. Armour thyroid and P-thyroid was preferred to the plain synthetic levothyroxine because it has both the T4 and the T3. So even though we call bioidentical is better than natural, they are synthesized. They pick up yam, sometimes from the soy, and or the process that they use chemically, they come out and extract to estradiol, progesterone, testosterone, or DHEA, which is exactly, it look like in the structure and the effect as a natural produced by the body. There is no such a thing, or natural human hormones. Would be impossible and very prohibited.
Right.
Imagine get pregnant women to donate their urine so they can do that, would be prohibited. So, so we should call bioidentical, and the others we should call non-bioidentical, because synthetic, and they're all synthetic in a way. You know what I mean?
Yeah.
But for example, if you need progesterone, you cannot substitute it with medroxyprogesterone. This is what it gives the hormone replacement a bad name. 2002, they published the study on the Women's Health Initiative. They found out that women have intact uterus. They decide to use the Premarin for estrogen, and they added this medroxyprogesterone, which is the name is misleading because they look like it's progesterone. Even doctors to today think it's the same thing. When you change a little radical, a little chemicals here and there, it could change completely the action. So that hormone is carcinogenic and is associated slightly with risk of breast cancer. And this is what the scary body stop using. But the women that taken the Premarin continuously through the years, after 2019, the study published again, but nobody reads that. It shows that those women, because those women have hysterectomy, say they thought that they didn't do progesterone, which is wrong. We need progesterone also to protect your breast. But anyhow, they decided not to, and I'm glad they didn't do it, because that gave us the opportunity to find out that no, estrogen is not the cause of breast cancer. So those women that they follow through, still today, they find out that there are no increase of breast cancer compared to the maybe slight decrease. And if develop breast cancer, there's a milder form and with low chance of mortality compared to the ones that never took any hormones. So now this study just that put the last nail in the coffin.
Yeah.
It's not the cause of breast cancer.
Breast cancer.
The reason why is just doctors, oncologists, unfortunately, and they are on the same boat. They are looking at the old literature, 2002. They're fixating, because at that time also, there was an article saying that women after menopause, for example, they were associated with breast cancer. Associated. As you know, if you're a PhD and you study a lot, and you know, as a physician or being in the medical field, association is no causation. Not because they're associated with breast cancer. You have to find out if they're doing that association study. Tell us, let's do a hypothetical question here and now. Is estrogen the cause of it? So that generates hypothesis. Then you prove it using estrogen in a double-blind placebo-controlled studies to prove if there's a problem or not. And it's being done. And it's more data now that we have not a couple of years ago, that estrogen given to women doesn't increase breast cancer. What happened those women, they're postmenopausal with increased estrogen levels, is because they have insulin resistance. They are metabolically fat. They have visceral fat that converts all the androgen into estrogen. But the cancer is not produced by the estrogen. It's produced by the insulin, high insulin levels, and the inflammation. Cancer is an inflammatory disease. So that they got it wrong. The high estrogen was bystander. It was a passenger. Another study showed that women in perimenopausal that have high testosterone levels have an increased risk of breast cancer. But they have natural
testosterone.
The problem is they are not taking testosterone. Like the other women postmenopausal, they were not taking estrogen.
Right.
They find out that perimenopausal women with higher testosterone level associated with an increased risk of breast cancer. Those women have PCOS. They're inflamed. They have insulin resistance, high cortisol, because they get gas in hand, high insulin, high cortisol. So they are inflamed and insulin resistant, and breast cancer is an insulin dependent tumor, and also an inflammatory, because cancer is an inflammatory disease.
Right. I think that's so important.
Unfortunately, there are also, somebody's very gutsy right now to give hormone replacement bioidentical to women after breast cancer. 40 studies are done that proven that not increased risk of breast cancer. But unfortunately, medical, legal, even if you have it, if you come to see me, I cannot do that. Because the minute you have a recurrence, because there are some recurrence of breast cancer, I may lose my license.
Right.
It is embedded into the mentality that estrogen is the cause of cancer. And there's nothing we can do to teach doctors, because they're fixed. They believe on that, and that's it. There's nothing you can change. You know what I mean? It's like, you cannot, like my professor said, you cannot teach the pig to sing.
I think that's so important. When I was taking my hormone course for Institute of Functional Medicine, that was one of the things I found really fascinating, because I also thought well, I didn't really know enough, but just to hear how many studies were done that proved otherwise, and that hormone replacement estrogen is not the cause of breast cancer, I think is so valuable for you to be able to share that with people. So I think that's really important.
It's a shame that women are suffering from this, all the consequences, and not only the symptomatology. The suffering with the menopause is, we know that hormone replacement, bioidentical hormone replacement, will decrease cardiovascular disease in the postmenopausal women.
Yes.
50%, 50% osteoporosis. 35% overall mortality, and now not new study, 85% of Alzheimer's. That's a big one.
Yep. So it's
women the harm right now for women menopause is not taking the hormones. Now, of course, women taking hormones, they have the same incidence for breast cancer, the woman you're not taking it. But anybody that makes conclusions on the right data that we have.
Right.
So
now, when
we talk about optimizing hormones, another version, maybe it's a little different from the functional medicine approach, that we believe on the data that we cannot, the data shows that the estrogen will be protected if it's balanced with the estrogen and the progesterone and the testosterone. And also we look at DHEA as a hormone, very important. Melatonin is essential, whether not for sleep anymore. Melatonin is essential for as an anti-inflammatory. It's essential for antioxidant, prevents oxidation of bad cholesterol. So improve your immune system. It's just phenomenal. So we look at balance all the hormones. Optimizing means bring the levels to the upper level of normal. Because guess what? As we get older, our receptors become resistant. This is a new concept for me. And, there's no share by other doctors. They're still in the old-fashioned thinking, well, you just a little bit of this, a little bit of that. And I've done that. We can extrapolate. We cannot say, okay, look at that estrogen, what I said, beneficial of bioidentical hormone replacement in women after menopause will decrease osteoporosis, breast, cardiovascular disease.
Decline.
But we cannot, the studies are shown when the levels are pushed up to the limit. There's no study that show using a minimal. We don't know, but there's no studies to prove that minimal amounts will do the same effect. This is a thing that disagree a little bit, with the functional medicine academy. Maybe the force is the 4 a.m. The American Academy of Anti-Aging, they are still using mini amounts of hormones, and they're not going to
finding still all of those benefits, right?
Yeah.
So just with
We can't promise that. But unfortunately, I've done it, thinking that was okay. But then when you start digging into more information, disadvantage right now, that advantage of the COVID, I was able to do 88 hours of, of advanced bioidentical hormone studying.
Of course you did.
Yes, I got a certification. You know what I mean? Yeah.
Amazing.
And my wife said it to. She got a certificate and told my grandchild, "Look, I see, Grandpa, you got at 76, got the degree." You know what I mean? You know, to encourage them to be
Oh, to be just like you.
and study. Yeah.
Absolutely. That's amazing. So, Dr. Beninati, when someone comes in, are you having them do some kind of hormone testing for every patient? And if so, what does that look like? And do you use certain testing?
Right now, the people know what I'm doing, so more or less they come up. I would say from the front door. They already
Kind of know.
to spend that. Yes, we used to do see the patient, evaluate them, and then order blood work, but that's a waste of time for the patient and I. But you have to be careful, because anytime you order some blood work, you establish a patient and doctor relationship. You're responsible for the lab work, okay? But we told the patient to make an appointment, and we send the lab work ahead of time. In general, some patients may don't do that, but in general, we do that. We prefer that.
Okay.
I have an idea what's going on.
Okay. And then do you do salivary testing? Do you do urine testing?
Talk about testing. That's a good idea.
I got too far ahead.
No, but we can talk about how you test it. Studies are done on the optimizing the hormones on serum levels. And I've done the salivary test. And I found that was that was wrong, because I tell you in a minute. I thought that the urine test was the best, but there's no data. Maybe it is, but there's no data other than the studies that done by the companies that did that, which political, they're interested in that. That's, you see that where they're coming from. So, and the levels are done a certain time. For example, estrogen have to be checked 5 hours at peak, testosterone at 12 hours, progesterone at 9 hours, DHEA, thyroid, 5 hours. So we have it simplified. It's not that you have to do all this worry, but you go up at a certain time and it's all done. The data doesn't, I believe on the 24-hour, I've done it for many, many years. I abandoned about 2 years ago because I got burned a couple of times, because looking at the progesterone and the estrogen, the progesterone was enough to cover the effects of the estrogen in the uterus, and the woman's having some bleeding and issues and thickened endometrium. That was not. The studies have shown that you protected the endometrium when the serum progesterone is about 10 or above. But here's the problem with LabCorp. They changed the rules, and they did a purified form of progesterone. They have to multiply by 3.5 to come up to that number. So I got burned a couple of times with that. Salivary, the problem with salivary is good to know. I've done it, seen it for evaluation. If somebody has issues, get a salivary testing, we can tell what's going on. But to follow the patients with saliva after treatment is not reliable, because the saliva concentrate progesterone and give you and I've seen it refer to me, patients that came to me with bleeding and issues with doing salivary testing. And so they think that the progesterone is high. And believe me or not, I learned by doing the progesterone creams, very seldom work, maybe on the labia, but it doesn't work on the skin, because you need heavy dose, because the skin doesn't, and with time also you get we call hormones receptor fatigue. So we've seen that. And as a matter of fact, another doctor in California lost her license because she was following the patient, and the patient bled, and she kept doing following the saliva test. The saliva test showed that she had a lot of progesterone. She ended up with severe endometrial cancer.
Oh no.
And she didn't follow the protocol. First of all, if you have bleeding, Even if you think that, you need an endometrial biopsy to find out if you have an endometrial cancer or not. So the bottom line is the salivary could be very misleading.
Okay.
So, but if you do hormones, we can talk about. I'll show you, the data when to the best time to do it. And if you're not to know in women, there are perimenopausal. If you're not to do more, it's during the 21st year of the cycle to see what the progesterone estrogen ratio is.
Mm-hmm.
But most likely, women are perimenopausal. They all need progesterone. Mostly, they have irregular cycles. They have irritability, PMS. You know what I mean? It's although I use a lot of natural products. I've used Chaseberry Plus, imipramberose oil, but sometimes that's not enough. I started with that, but when the levels are so low, then they feel great. In the perimenopausal women using progesterone and testosterone, for example, that's and DHEA, melatonin, and another hormone, which is not a vitamin anymore, is vitamin D.
Mm-hmm.
Vitamin D, as you study, we thought it was a vitamin. Well, vitals, if it comes, if you have to take it, if not, you die. It come from the food, vitamins, vitality.
Mm-hmm.
But no, we have an organ that makes vitamin D from cholesterol. Cholecalciferol is a hormone, and also there's no receptor for vitamins, but vitamin D has a receptor. It is a hormone. If that's my professor say, if it talks like a quack and walks like a quack, it's a quack. It is a dog. It's a dog. That's I'm if it talks like a duck and quacks like it's a duck. So in a way, it's an important hormone that's being neglected. We need to get the levels of that. And with the RDA, which is ridiculous recommendations, 800, you don't get anywhere with that. You need to get up to the level of 50, or it's another important hormone for immune system, mostly for the pandemic right now. Mm-hmm. As you know, right now, talking about the pandemic, inevitable. The real pandemic here is insulin resistance. 89% of Americans are metabolic unstable. This is terrible, as you know.
Yeah.
This is a true pandemic, because it loves the insulin resistant inflammation. They get more inflamed. You don't need to more. The virus come in, and if you're inflamed, that's super inflamed. That's what it kills people.
Right.
So the vitamin D, melatonin, very important for protection with zinc, of course, exercise, like relaxation, sleeping, alcohol, sugar.
Drinking alcohol or not drinking alcohol?
As you know, right now, there's no safe amount of alcohol. Other than we enjoy a glass of wine, it's for enjoyment, but we don't need to consume alcohol to be healthy.
Right.
That's all lies. It's all lies. One, okay. I'm taking off.
So just to circle back for one moment.
You asked me a question earlier. I think we were talking FDA approved or non-FDA approved.
Yeah, before I go there though, just to circle back, did you, so if you don't necessarily do the saliva testing or the urine testing, you're doing blood testing?
Yes.
Okay. I just wanted to confirm.
3 years ago, I was doing the urine.
Okay.
It's more reliable than but no, the saliva testing and testing, I got used very short period of time, and I didn't like the results in the patients, you know what I mean? But if you're doing many amounts of hormones, what the patient gets better. Sometimes they do feel better a little bit. But we are beyond that. I used to believe on that. Now we look at longevity. I look at long-term effects on hormones, because my practice mostly is patients that are wanting to live healthier, and they're in the 50s, 60s, 70s. They wanted to improve their overall health, and they know the importance of hormones. And believe me, if you do exercise, you eat healthy, and balance your hormones, you're going to have a successful life, healthy, without any of the major disease. You won't consume pharmaceuticals for sure, because it's a vicious circle. If you balance your hormones, you won't have depression, that you have to eat candy or start to alcohol for that. Okay, you be motivated. You feel great. You feel exercise. You have more energy. So it got in conjunction with nutrition and exercise. You know, that's important. And we know that estrogen, guess what? Estrogen also proven, and DHEA lowers cortisol. So, you know, you can do too much with relaxation, but you need to help them too, okay? So that estrogen will decrease cortisol.
Yeah, and that's a great way to think of it too. Kind of the question I had earlier is just when someone does have significant symptoms, like a mutual patient that we have now, where there's so much stress and so much, you know, anxiety and all those things. If the hormones aren't balanced, then you could do all the right things but still feel really terrible. So I think that's where they can be really, really powerful in an overall approach.
Definitely. It has to be a holistic approach. When they come here right now, I said, I'm a holistic doctor. And I say, I listen to the whole list. Holistic. You have to hear to the whole list.
You do have to listen to the whole list.
I never liked the word. I know. I never liked the word, the holistic, you know what I mean? Because like holy pokey, you know what I mean? I never liked that, the concept.
I know.
Integrated medicine.
Integrated medicine.
I'm talking about preventive and innovative medicine. That's what that's the beauty right now. That's what I'm trying to do right now.
I'm with you on the holistic. I always say I don't really like to use that word, so I always use integrative. So good, we're on the same page.
Unfortunately, for the mainstream medicine, prevention is early detection. Well, we don't want to detect anything. There's no real prevention. One is early. That's the extent they call preventive medicine. That's not preventive medicine. Early detection. No, you don't want to do that. You don't want to be in that boat.
Right.
Yeah.
So how can these bioidenticals be administered? So what do you typically use, whether it's pellets or you talked about the creams a little bit?
A pellet, it depends on the preference. Pellets, creams, okay. Sublingual could be some oral, depends on the hormones, okay. And DHEA, for example, is hormone. Melatonin is also. We use testosterone could be in women, could be a pellet, it could be a cream, and it could be also sublingual. Estrogen could be also in a pellet, and oral, okay, or in a cream. And progesterone is by mouth. Now we use oral, or sometimes we use a sublingual, depends on that. But the levels we want to do, we need to get the levels to protect the endometrium, and and bleeding is an issue. And if the woman bleeds on the hormones after menopause, nobody likes to bleed. Number one, women they're done with the cycle, they're done. But not only that, that could be a sign of that overgrowth of the lining. And we knew that in the 60s, late 60s, when the Premarin came out, every woman was taking the Premarin. Guess what? We saw a lot of people with endometrial cancer, because you give estrogen unopposed to progesterone, you end up, of course, there are some warnings before that. You get endometrial hyperplasia, and from that, you can progress to endometrial cancer. We've seen in the 70s, a lot of people with endometrial cancer, because at that time they realized, hey, we need progesterone. But guess what? The progesterone was available, but the pharmaceutical decided to let's modify, trickle the formula to create something that is patented, could be patented. So they call medroxyprogesterone. And this is a disgrace, because that increased clotting and an increased definite breast cancer. So so oral is the way to achieve the levels, although I see some patients doing intravaginal too, and some few patients they do on the labia, because the labia, it is sema mucosa, so its absorption is greater. But transdermal, see, in my practice right now, you don't want to waste the time, the patient, and my time. So we'll give you things that work. So because I've been doing by experience, you know what I mean? It works better that way.
Yeah, you've only been practicing for a couple of years, right?
Yeah. Yes, you learned a lot by time.
Yeah, which is amazing.
Yes.
So any final thoughts on anything, Dr. Beninati?
We talk about the FDA, that you're going to hear that
Yeah.
because when I was doing OBGYN, I heard that coming from the reps, and that, oh, there's no regulated by the FDA, and well, the bioidentical hormones, they're not regulated by the FDA, but guess what? Any hormones that we use are approved by the U.S. Pharmacopoeia that works in relationship with the FDA to allow this product to be in the market or not. Then the manufacturer, so what we use is they use hormones that are approved by the USP Pharmacopoeia,
Okay.
which is work with FDA. And then the manufacturer is under the strict guidance and control of the Board of Pharmacy of each state. Now, sometimes the FDA goes and checks them too.
Okay.
And it's matter of fact, there's a pharmacy up in Massachusetts. They do an intravenous, when in that way they would put it into the spine.
Mm-hmm.
And the manufacturer was awful. There was a corruption because the one member wasn't a member of the pharmacy, no inspection, and they got bacteria, and a couple of people died. So the FDA came in, so they closed that, and they, because they said that was not a compounded pharmacy. That was a mass-produced pharmaceutical.
Mm-hmm.
This is what the FDA does. The FDA is under control of the mass-produced pharmaceuticals. So if you're doing a mass production of bioidentical, you're a factory, then you go under the FDA. But anyhow, that was corruption. But in general, the U.S. Pharmacopoeia works in conjunction. If you look at the U.S. Pharmacopoeia, you'll see the strict guidelines they have. So now the problem sometimes is the compounding. Sometimes it's the physician. Sometimes they start doing this, and they don't know what they're doing, and I've seen it bad results. Okay, so the hormones are very, very powerful, mm-hmm. but you have to be respected, and you have to be taken in conjunction. You cannot take estrogen without progesterone, for example. Okay. You have to be balanced.
Right.
So,
any success stories that you have that you want to share?
Well,
I mean, I know there's tons, but if there's anything that jumps out.
Well,
or just someone.
So many. I think that at the end of the day, I feel like we have a wonderful nurse. Also, this is my right hand. She is been working for me for years, and because she gets the first pulse, and so she's excellent too. And we have a lot of success stories. We have in the functional medicine, I can tell you one right now, a woman with, as I saw the other day, she has this GERD, and then she has this problem with, we call Barrett's esophagus, that is precancerous. So they put her Nexium, and then she came to me, there's some alternative. I said, well, Ben, I cannot tell you don't take it because you have a serious condition. So I recommend a product, I probably it's called the Ketogenics. There's aloe and the glycolize licorice and glutamine, and then the girl was gone. She went to see the doctor doing endoscopy, and it's gone. Wonderful, you did
That's
wonderful.
Awesome.
But doctor, I didn't use your Nexium. What do you use? Aloe. Aloe. That will do it. This gastroenterologist knew the aloe could heal and prevent that. Of course, she came to see me. We talked about the certain nutrition. We got the nutritional support, enzymes, probiotics, and so on. I saw, a young man, 47, with testosterone down to around 300, that would put, because of the cholesterol was high, they put in statins. So the cholesterol came down to 120.
Wow.
So he wasn't making testosterone.
Right.
Was overdosed with that. So we put the testosterone up, and and then I'll send it to some studies. And why? High cholesterol doesn't mean that you're going to have cardiovascular disease. It
Mhm.
could be a risk factor, but you have to dig into more others why the cholesterol's up.
Right.
So I'm a lot of success right now. You know, treating cholesterol, of course, high cholesterol with nutrition, lower your cortisol,
Mhm.
increase your thyroid. Even though your thyroid is within normal range, guess what? T3, which is the lipothyrene,
Yeah.
the liver used to clear the cholesterol and the triglycerides. So it's because you have a belly fat. Remember, 89% of us have this insulin resistant issue. Of course, insulin also produce because you are in the storage mode. You
Mhm.
storage fat, you make more fat.
Mhm.
So, so cortisol is another one in the second degree also. High cortisol also will do the same thing.
Right.
So we have to go to the root of the problem. If not, given the cholesterol medication, that's this like, if somebody
Like
has
a Band-Aid on.
you have a brain tumor and you need surgery and you give it something morphine, you're taking pain medication and the pain is gone, but you still have the tumor there.
Right.
So unfortunately, medicine is very conducive to treat the symptoms type of medicine with prescription.
Right.
And unfortunately, doctors have 10 minutes to see a patient. I was there when I was doing part of the University of Pennsylvania when delivering babies, the gynecology. We have 10 minutes with each patient, no more. If not, the nurse will knock at the door. And I hated it because the woman has another issue. Maybe she another need to be heard or something,
Yeah.
emotional that affected her. You know what I mean? No time. Oh, go to see the psychiatrist or go to see this, and you dilute the patient with multiple specialties.
Right.
Whether the problem is as you know, go to the functional medicine. Why is that the
Mhm.
root of the problem?
But that's why you're doing what you're doing, and that's why I'm doing what I'm doing now. Taking more time with patients and really listening to their whole story. And
Well, unfortunately, I have time, and I enjoy. It's like a hobby for me right now. You know what I mean? But I
yeah,
need, um, we still accept some insurance, but when people do what we do, they don't accept insurance because the insurance
Yeah.
not going to pay with the time you spend. And
Right.
people think we have elves in the office. Your
Mhm.
phone call, he answered the phone call. Who's going to get the nurse? Who paid the nurse? You follow me? So
Yep.
all the expenses we need to do, and the malpractice, and office space, and all the things that involve when they establish a practice. But you cannot make it, with that. Now the doctors, how do they do it? GPs are not happy either because they have to see so many patients an hour to make ends meet. The whole system is, as you know, and they don't incentive to do any functional medicine. It's mostly symptomatology based,
Right.
and there's no. A couple of years ago, I I have a weight loss program based on ketogenic diet. It's a program, that's all. The nurse follow is no secret ingredient. It's the fact that you committed to the program, look at ketones in the morning, and of course, it's not ketogenic all day. It's semi-ketogenic, but they see that for me to assure that they're losing the weight.
Mhm.
So the Blue Cross called me and I said, well, because the woman tried to submit it to the insurance. So this is to prove they're not, the insurance company are not also in the preventive medicine. And I said to the woman, I said, there would be a wrong thing for the Blue Cross to pay for this particular patient weight loss. They should do this to the patient. You lose your weight, you keep that weight for a year, and I will give you 80% what you spend. Because if it's a free one, and this is what happened with weight, if it's a free advice, you get it. People don't do the follow-up. When it costs money that you
Right.
to come to the office and pay for
Right.
that, then you will apply and do the program. But anyhow, so there, and you know what she said? Well, we are not set to do that. I said, well, you could, because it's preventive medicine. If the
Right.
patient loses the weight, she won't have insulin resistance, the cholesterol is going to be normal. She won't need to do statins. She don't need to do all the things you do, the arthritis and pain and arthrosis and back pain, and I think great by obesity.
Mhm.
Blood pressure is another one. You know what I mean? So, but it just, you're not set for that.
Right.
Okay. I take
So,
patient off. Okay, sure.
oh, go ahead. Go ahead.
No, antidepressants. You know what I mean? Everybody that doesn't fit the program, they put an antidepressant. We have to see why you're depressed.
Mm-hmm.
You know what I mean?
Yeah.
Could be an emotional issue. You try to solve it, but sometimes because if you are metabolically obese, you have a lot of extra fat, you're going to be depressed, no question. It's an inflammation.
Mm-hmm.
And it started in the gut also. Of course, the gut is also inflamed. So good or rule the problem. You may need an antidepressant to get out from this crisis. If you think that the patient is going to kill himself, that's dangerous. But then after that, they don't work long term.
Mm-hmm.
You see the warnings you have right now, increased risk of suicidal. That's truth.
Right.
And nobody goes through the problem.
And 90% of all of our disease is linked to excessive or persistent inflammation. So
start in the gut, right?
Yep.
That's what you said, okay?
Yep. Start in the gut.
Diane said that you are what you eat.
Mm-hmm. I love it.
As I said before, if you balance your hormones, it's an incentive to keep you healthy, no question.
Yeah.
The hormones itself, without the exercise and the optimal weight and exercise, and it's not going to work.
Mm-hmm.
But it helps to achieve those goals and keep off in the healthy range.
Right.
I'm fascinated with nutrition, and this is I will never retire. So retirement is not.
I know you can't retire now because I'm going to bug you all the time.
Sure it is. I love it. Yeah.
You are so amazing, Dr. Beninati. I cannot thank you enough for this.
You have a few questions. Let me see what question you asked me. If I answer all that, you
did. Yeah. So we pretty much
talked about breast cancer. Yes, we talked about breast cancer. Yes. Yeah. The FDA. I'm just looking at we were talking earlier. So I think we we can do it again this time, maybe part 2 or whatever.
Absolutely. Yes. Thank you so much. How can people find you? How can people find you?
At my webpage is dr from drbeninati.com.
Okay.
Dr. Daniel Beninati.com.
Dr. Daniel Beninati.com.
My phone number is 610-269-9010.
Awesome. And I'll
down into a number.
I'll make sure to put that contact information for everybody. But thank you so much. You are absolutely amazing. So knowledgeable. This was incredible.
We're gonna have some lunch together.
Yes, I would love to.
When we're allowed. When we're allowed.
I'm gonna just stop the recording. One moment.